Hi, Lokesh. I was actually looking for you. I thought.
Good evening, ma'am. Ma'am, I was traveling. That is why.
No problem. No problem. Now we have open. It's all open right now, so we will not chit chat.
Can we start the session?
Yeah. Good evening, all. Welcome to this month's session on pyridoxine-dependent epilepsies, and will be taken by Professor Sangeeta Yoganathan, and we have Professor Vinayan and Professor Mahesh as two experts. And to moderate, we have Jyotsna and Lokesh Saini. I request Dr. Mini to say hi before we hand over to Lokesh and Jyotsna.
Good evening, everyone. Dr. Jyotsna, you can start.
Yes, ma'am. Am I audible?
Yeah.
Yes. So, good evening, all, and welcome to this Pediatric Neurology Subsection academic session. And today we are talking about a delightful topic because any clinician who has treated and seen pyridoxine-dependent epilepsy knows the joy of a pediatric neurologist treating it. So, to talk about this topic, we have none other than Dr. Sangeeta Yoganathan. And you know that she's a doyen of pediatric neurology, especially the metabolic spectrum. And we thank you, ma'am, for giving us your time and giving us this session. I invite Dr. Lokesh sir to introduce the moderators.
Good evening, everyone. So I invite Professor Binian sir and Mahesh Kamathe sir, and we all know they are like who they are and what work they do. Experts in this field, pediatric neurology, especially epilepsy. And Binian sir has a special love for pyridoxine-dependent epilepsy. So that is why we have requested Binian sir to be one of the moderators. And Mahesh Kamathe sir is another expert in this field. So let's go ahead with the talk. And moderators, please, we can introduce speaker.
Yeah.
Yeah, thank you, Lokesh. Over to Mahesh. You introduce, Sangeeta better than me.
Yeah. Good evening, everyone. Sangeeta Yoganathan is a professor in the Department of Pediatric Neurology, Institute of Neurological Science in CMC, Vellore. She had done her DM from AIMS, New Delhi. And after that, she also done a fellowship in sleep disorders and fellowship in neurometabolic disorders and neurostimulation from Toronto's Hospital of Kids, Toronto. She's especially interest is neurometabolic disorders. She did a lot of work in the field of neurometabolic disorders. Without further ado, I would hand over the platform to Sangeeta and to give her talk. Over to you, Sangeeta.
Thank you, sir. Thank you for the kind introduction. Am I audible?
Yes, audible.
Yeah, very well. So,
Sangeeta, while you share your screen, I want to tell everyone she has been one of the most sincere residents whenever she was doing residency with us. So one of the most wonderful human beings besides an excellent professional. Yeah. All yours, Sangeeta.
Thank you, ma'am. Good evening, everyone. I thank IN Pediatric Neurology subchapter for this kind invitation. So the next 30 minutes, we'll be focusing on the spectrum of disorders of pyridoxine metabolism. We all know vitamins are essential for the functioning of enzymes involved in various metabolic pathways of protein, carbohydrate, and fat metabolism.
Sorry to interrupt you, but
yeah, your slide is not visible, no?
Was it? Okay.
Your slide is not visible, Sangeeta.
1 second. Is it visible now?
No. So, Smita, what is the problem? So it's...
It says...
ma'am, you have to select the PowerPoint.
Yeah, I have selected the PowerPoint and I've shared. It shows me Zoom is sharing a window.
Yeah, this then go back to this PowerPoint because I can see your entire Zoom window.
So I'm currently in the PowerPoint.
Okay, do one thing. I'm just stop your sharing. Open your PowerPoint, put it on the slideshow mode, and then share the screen.
Yeah, good.
Sorry for the technical glitch. We all know vitamins are essential for the functioning of enzymes involved in the various metabolic pathways of protein, carbohydrate, and fat metabolism. So these vitamins are not only important for the cellular energy metabolism, but they also exhibit antioxidative and neuroprotective effects. They are important for both myelin synthesis and neurotransmitter synthesis. So vitamin deficiency results not only from incomplete intake in the diet or defect in the absorption of the vitamins, but also can result due to the synthesis of defect in the synthesis of cofactor forms. So the spectrum of clinical manifestations in vitamin-responsive neurological disorders is highly variable, ranging from encephalopathies, developmental delays, epilepsy, movement disorders, myopathies, and neuropathies. It is important for the clinicians to diagnose these group of disorders because many of them have a potential treatment implications and which will improve the long-term neurodevelopmental outcome. So this slide shows the list of fat-soluble and water-soluble vitamins, which are essential for the functioning of various enzymes in humans. So in this discussion, we'll be focusing on the pyridoxine metabolism disorders. So the pyridoxine in the diet exists in 3 forms. So it exists as a pyridoxal phosphate, pyridoxamine phosphate, and pyridoxine. So when it is a phosphorylated form, it cannot be absorbed across the intestines. So the intestinal phosphatases act upon it, and they result in the production of pyridoxal, pyridoxamine, and pyridoxine. So once it gets absorbed from the intestine into the circulation, again it is acted upon by the kinases, where it gets rephosphorylated. So these phosphorylated forms enters into the liver. The liver has the most important enzyme PNPO. So this PNPO is essential for the synthesis of pyridoxal phosphate, which is the active form of pyridoxine. So this pyridoxal phosphate then enters into the systemic circulation and it reaches the different cells, target cells. So once it reaches the cells, it cannot directly get transferred across the cell membrane in the phosphorylated form. Similar to in the intestine, the phosphorylated form cannot be absorbed. So at the cellular level, the phosphorylated form cannot be transferred across the cellular membrane. So it is acted upon by the tissue non-specific alkaline phosphatase to form the pyridoxal. So once it is entering into the cell, within the cells, it is again acted upon by the kinases to form the pyridoxal phosphate. Finally, we get the pyridoxal phosphate, which is the active cofactor for the many of the enzymes involved in the synthesis of carbohydrate, protein, and the fat metabolism. So there are about 140 reactions, biochemical reaction in the living beings, which are dependent on this pyridoxal phosphate as a cofactor, out of this, about 70 occur in the humans. So this pyridoxal phosphate is essential for the amino acid metabolism, neurotransmitter metabolism. It is essential for the carbohydrate and lipid metabolism. It's also essential for the heme synthesis and mitochondrial functions, and it also regulates the synthesis of polyamines and proteins. Apart from this important functions, the pyridoxal phosphate also exhibit antioxidant properties. It affects the immune function. It acts as chaperones at the cellular level, and also it acts as an antagonist of ATP at the purinoreceptors. So what are the pathomechanisms by which vitamin B6 dependent epilepsies occur? It can occur because of the impaired formation of pyridoxal phosphate, or impaired uptake of pyridoxal phosphate, or inactivation of pyridoxal phosphate because of accumulation of certain toxic metabolites within the cells, or impaired PLP, pyridoxal phosphate homeostasis within the cell. So among this four group of pathomechanisms, we will first focus on to the accumulation of the metabolites that inactivates the PLP. So there are two gene defects which can occur during which can result in the accumulation of metabolites that inactivates the PLP. One is the aldehyde dehydrogenase 7A1, another is the aldehyde dehydrogenase 4A1 defect. So we'll look into illustrative example. A 4-year-old boy, second born to third-degree consanguineous parents without any prenatal or perinatal risk factors, presented with seizures from the early neonatal period. So he developed a multifocal clonic seizures occurring as a status epilepticus on day 10 and day 11 of life. He was treated as a late onset sepsis with antibiotics and multiple anti-seizure medications. Despite this, he continued to have persistent seizures. On day 29, he was treated with pyridoxine elsewhere. And he had a good control of seizures, following which he was discharged on pyridoxine, folic acid, and levetiracetam. The parents discontinued pyridoxine at 15 months and 21 months. And again, child had status epilepticus during this point of time. And child had mild global developmental delay. There was no significant family history. So examination revealed microcephaly and bilateral convergent squint. Otherwise, there were no focal neurological deficits. So you can see in the MRI, the sagittal section, there is dysgenesis of corpus callosum. The EEG was normal and the metabolic lab workup was negative. So this child, on the clinical exam study, we identified a pathogenic variant in the homozygous state of aldehyde dehydrogenase 7A1 gene, confirming the diagnosis of pyridoxine-dependent epilepsy. So this child was continued to be managed with pyridoxine and levetiracetam. On follow-up, he continued to remain seizure-free, and he had gradual developmental gains later. So the pyridoxine-dependent epilepsy, the pathway which is involved is the lysine degradation pathway, which is important which is affected in aldehyde dehydrogenase 7A1 deficiency. So the lysine degradation occurs through two pathways. One is the saccharoperin pathway, which occurs in the mitochondria. Another is the pipocolic acid pathway, which occurs in the peroxisomes. So when there is a defect in the antiguitin gene or the aldehyde dehydrogenase 7A1 gene, there is accumulation of alpha aminoadipic semialdehyde, which gets converted into piperidine 6-carboxylase. So as a result of increase in the piperidine 6-carboxylate, it causes a chemical condensation and depletes the pyridoxal phosphate levels within the cells. As a result of which you have clinical manifestations because the pyridoxal phosphate dependent enzyme functions are affected. So children with pyridoxine-dependent epilepsy can exhibit classical presentation or atypical presentation. In those with classical presentation, the seizure often starts within the first few weeks or first few months of life. They often have polymorphic seizures and recurrent status epilepticus, and electrographic seizures can also occur in this group of children. The atypical presentation, they have a later age at onset between the late infancy to 3 years of age. The seizures initially respond to anti-seizure medication, but later can become intractable, or initially they do not respond to pyridoxine, but later get subsequently controlled with pyridoxine several months later. And they can also have prolonged seizure-free interval even despite the discontinuation of pyridoxine. So the spectrum of clinical manifestations in children with aldehyde dehydrogenase 7A1 deficiency includes global developmental delay, behavioral abnormalities and psychiatric manifestations. and tone abnormalities, movement disorders, and polymorphic seizures, which are often refractory to the anticonvulsant medications. So what are the biochemical markers that can be tested in these children? So the urine, CSF, and plasma can be collected and stored at -20 or -80. And as these compounds are very thermolabile, the temperature has to be maintained in stringent precautions. And you have to estimate the ASA levels as well as the pipicolic acid levels, which can give us a clue. So the International Pyridoxine-Dependent Epilepsy Consortium recommended the following doses for the management of pyridoxine-dependent epilepsy. In newborns, the dosage is 100 milligram per day. And infants, it is 30 milligram per kg per day. The maximum dose is 300 milligram per day. In older children, adolescents, and adults, the dosage is 30 milligram per kg per day. So the maximum ceiling dose is 500 milligram per day. So when these children are on maintenance doses of pyridoxine, when they develop intercurrent illness or a febrile illness, they can have a reduced seizure threshold. So to avoid breakthrough seizures with an intercurrent illness, we can double the dose of pyridoxine for a few days until the acute illness resolves. So is there a role for a triple therapy, which is this lysine reduction therapy? So along with the pyridoxine supplementation, lysine can be restricted in diet. As we know that it's an enzyme which is involved in the lysine degradation pathway. If you restrict the lysine in diet, we can reduce the accumulation of P5C, and we can also reduce the accumulation of the ASA. So the lysine restricted diet can be used along with arginine supplementation. So the arginine competes with the lysine at the level of the intestine as well as at the level of the brain for transfer. So the level of evidence for the triple therapy is only limited to the case reports and a few case series. So this is the algorithm for the B6 trial. So if you have a neonate presenting with seizures of unknown etiology, which is resistant to first-line anti-seizure medications, so after collecting the biochemical markers, if the testing for the same is available, we can give a trial of IV pyridoxine, but this has to be done in a control setting because there is a risk of apnea with IV pyridoxine administration. And if, or oral pyridoxine can be administered 30 milligram per kg per day. In divided doses for 1 to 3 days. If there is no response, we can consider adding folinic acid 3 to 5 milligram per kg per day in divided doses. If there is no response to pyridoxine and folinic acid, we can try switching to the pyridoxal phosphate 30 to 60 milligram per kg per day in divided doses. If the seizures respond, then we can continue with the pyridoxine or pyridoxal phosphate till the genetic reports are available. So we will look into the second genetic defect, which causes the accumulation of metabolites that inactivates the pyridoxal phosphate, which is the aldehyde dehydrogenase 4A1 defect. This is an illustrative case which has been published by colleagues from PGH Chandigarh. An 11-month-old girl presented with recurrent seizures, lethargy, and regression of milestones. She was born first in birth order to non-consanguineous parents. There were no prenatal or perinatal risk factors. The seizures etiology include fever-provoked generalized tonic-clonic seizures and epileptic spasms. After the onset of spasms, she had excessive irritability and regression of milestones. Following an upper respiratory tract infection, she had developed breakthrough seizures with altered sensorium. Examination revealed subtle dysmorphism with hypotonia, perioral and limb tremors, and respiratory distress. So this was the EEG, which was showing a burst suppression pattern in this child. And MRI was showing non-specific white matter hyperintensities along with diffusion restriction in thalami and the central pontine tegmental tract. So the metabolic workup in this child revealed elevated proline levels along with a mild elevation of ornithine. The genetic testing confirmed the diagnosis of hyperprolinemia type 2 due to the defect in the aldehyde dehydrogenase 4A1 gene. So these are the 6 enzymes which are involved in the proline metabolic pathway. So the hyperprolinemia type 2 results from defect in the P5C dehydrogenase, which is the pyrroline 5-carboxylic acid dehydrogenase. So this is the metabolic pathway. The defect here is the P5C dehydrogenase deficiency, as a result of which there is accumulation of P5C within the cells. So this accumulation of P5C again depletes the pyridoxal phosphate level within the cells, resulting in the dysfunction of these enzymes, which are pyridoxal phosphate dependent. So moving on to the next group of disorders, which are vitamin B6 responsive, results from the synthesis of the results from defect in the synthesis and recycling of pyridoxal phosphate. So that is the PNPO deficiency. So we have already seen the synthesis pathway. So PNPO, I said, is an enzyme which is present in the liver, which is essential for the conversion of pyridoxal phosphate and pyridoxine phosphate to the active form pyridoxal phosphate. So when there is a defect in PNPO deficiency, the active form of pyridoxal phosphate is not synthesized, as a result of which we have the clinical manifestations. So these children manifest early in the intrauterine life, or starting with the intrauterine life. They can manifest with seizures, or they can have fetal distress before delivery. They can present with neonatal depression, perinatal depression, low Apgar scores. They can often manifest with difficult to treat seizures of polymorphic semiology, and they can present with epileptic encephalopathy. They can have tone abnormalities, roving eye movements, and movement disorders. Some of these children can have systemic signs, including failure to thrive, poor feeding, and respiratory distress and anemia. The late onset form is it can present like cryptogenic seizures, refractory to common anti-seizure medications. So the MRI's findings in this spectrum of a disorder is often non-specific. EEG spectrum includes burst suppression pattern, focal or multifocal epileptiform discharges, hypsarrhythmia, and few of these children, the EEG can still remain normal. So the blood workup can reveal anemia, because pyridoxal phosphate is essential for the heme synthesis. And it can also reveal hypoglycemia, elevated lactate, and metabolic acidosis, because few of the enzymes in the pathway of gluconeogenesis and glycogenolysis are also pyridoxine dependent. So the diagnosis is confirmed by the presence of biallelic variants in PNPO gene. So these children should be first treated with pyridoxine, because 40% of these children will respond to pyridoxine, because the amount of residual PNPO determines the clinical benefits. So if they have a good amount of residual PNPO activity, if you administered orally pyridoxine, it can be converted into the active form. But if the child has like a very limited residual PNPO activity, the pyridoxine supplementation might not be beneficial, which has been observed in 60% of cases. In those children, we have to supplement the pyridoxal phosphate. The pyridoxal phosphate has to be administered as the lowest effective dose possible to avoid the liver toxicity. And also we have to consider avoiding medications or anti-seizure medications which can deplete the PLP concentration, particularly the carbamazepine, phenytoin, phenobarbital, and valproate. So there is a small subset of children who on pyridoxine or pyridoxal phosphate show a partial response but still continue to have seizures. So a trial of folinic acid administration in these children may be helpful. And a small subset of children who are having mutations in the flavin mononucleotide binding site will benefit from supplementation of oral riboflavin. So we all think like the water-soluble vitamins are very safe, but with the pyridoxal phosphate, there is a risk of liver toxicity, because it's an aldehyde derivative which is toxic to the liver, and it can cause cirrhosis and can result in the risk for hepatocellular carcinoma. So those children who are on pyridoxal phosphate, we need to monitor the liver enzymes every 3 to 6 months, and more frequently if required. And also we have to keep them on an annual surveillance of ultrasound abdomen to monitor for the echogenicity of the liver, to monitor for the like if there is an occurrence of cirrhosis, or if there is a risk for developing the hepatocellular carcinoma. So there is one recent report of liver transplantation in a patient who with PNPO deficiency was managed with pyridoxal phosphate. Because of the pyridoxal phosphate toxicity, the child developed liver malignancy, which was managed with the liver transplantation. We might think like, because PNPO is derived from the liver, and if you transplant a healthy liver, so the child might have a decreased requirement for the pyridoxine or pyridoxal phosphate after the transplantation. Unfortunately, this does not happen, because the pyridoxal phosphate, once it enters into the cell, it forms chemical, it performs complexes with the other chemical processes in the within the cells, and also it gets converted into the pyridoxamine, PMP, which is pyridoxamine. So the brain does not have the PNPO which to the level which the liver produces. So when you transplant the liver, which a healthy liver, which has the PNPO in adequate quantities, but still the brain is depleted of the PNPO. So hence, these children has to be continued on the pyridoxal phosphate despite the liver transplantation. So we'll move on to the third group of disorders, which are vitamin B6 responsive neurological disorders. This results in the defect of import of PLP into the brain. There are two important disorders in this group. One is the hyperphosphatasia, another is the GPA anchor synthesis defect. So as I already mentioned, the pyridoxal phosphate cannot enter across the cell membrane. So it has to be dephosphorylated before it enters into the cell. So that this is done by the tissue non-specific alkaline phosphatase, which is encoded by the gene ALPL. So when there is a defect in the ALPL gene, these children can manifest with developmental delay, onset of seizures right from the neonatal period. In addition, they can have bone manifestations, including rickets and osteomalacia. So one of the biochemical markers which can help to establish the diagnosis is along with the clinical presentation, if you have a low alkaline phosphatase level, we should consider the ALPL gene mutation. So the second disorder which results in the defect of import of PLP into the brain is the GPA anchor synthesis defect. So if you see, the tissue non-specific alkaline phosphatase is anchored to the cell surface with the help of the GPA anchor. So when there is a defect in the genes which influence the synthesis of GPA synthesis, so then we can have again clinical manifestations which may be responding to the pyridoxine supplementation. So this table shows the list of genes which can result in the GPA synthesis defect. And in this group of disorders, the clinical manifestation include global developmental delay, dysmorphic phases, they can have skeletal manifestations, and they can have refractory seizures and developmental delay. So the biochemical clue in this group of disorders is that they can have an increased serum alkaline phosphatase, because tissue non-specific alkaline phosphatase is attached to the cell membrane with the help of GPA anchor. So when there is a defect in the GPA anchor synthesis, so the tissue non-specific alkaline phosphatase enters into the systemic circulation, as a result of which you have the elevated alkaline phosphatase. So the final group of pathomechanism by which the seizures can occur in children with vitamin B6 dependent epilepsy is the defect in the intracellular PLP transport. So this results from the mutation in the PROST gene, which is otherwise known as PLP binding protein or PLP protein homeostasis gene. So what happens is when the PLP enters into the cell, I said it is unstable and it forms chemical complexes with other cellular molecules, and also it gets degraded by the enzyme like phosphatases within the cell. So the PROSC is an intracellular protein which will prevent this reaction within the cells. It maintains the stability of PLP within the cell to maintain the the function of various enzymes which are PLP dependent. So the PNPB deficiency, the clinical manifestations are often similar to PNPO deficiency. They can have onset of seizures right from the intrauterine period. They can again have perinatal depression, and they can have developmental delay and polymorphic seizures, epileptic encephalopathy. And again, this group of disorders, these children can respond well to pyridoxine or pyridoxal phosphate. Some of the late onset forms can manifest with movement disorders and refractory epileptic seizures too. So the brain MRI the findings in this group of disorders include non-specific white matter abnormalities, cortical atrophy, simplified gyral pattern, periventricular cyst, and thinning of corpus callosum. There are no specific biochemical markers in this to identify this group of disorders. Genetic diagnosis genetic testing helps to confirm the diagnosis. So the management option includes first supplementation of pyridoxine, and if it is not effective, we can replace with the pyridoxal phosphate. So we have seen the four major pathomechanisms by which vitamin B6 responsive neurological disorders can be categorized. So like PLP-dependent enzymes dysfunction, how does it result in seizures? Because PLP is essential for the functioning of branched-chain aminotransferase, and also glutamic acid and GABA transaminase, which are essential for synthesis of glutamate and GABA. So as a result of this, there is a this imbalance in the excitotoxic as well as the inhibitory neurotransmission, resulting in the epileptogenesis. The other important non-enzymatic action of pyridoxal phosphate is whenever you have neuroinflammation, there is a release of ATP, and this leads to epileptogenesis by stimulation of some purinoceptors. So the PLP blocks this activation, and as a result of it, it exhibits an anti-seizure effect, which is different from the routine metabolic pathway mechanisms. So this is the GAD as well as the GABA transmitted enzyme, which are pyridoxine dependent, which are essential for the synthesis of the GABA. So we have often observed in our clinical practice, there are some other developmental epileptic encephalopathies which can respond to supplementation of pyridoxine. So this includes CACNA1A, GOD2 mutation related epilepsy, KCNQ2, and MOX2 or sulfite oxidase deficiency. So, so the mechanisms, as I explained previously, the pyridoxine can exhibit some anti-seizure effects independently of the metabolic pathways. Maybe the benefits are related to it. And in the molybdenum cofactor deficiency and sulfite oxidase deficiency, we typically see the accumulation of urine sulfite and sulfocysteine. What happens is this sulfocysteine inhibits the antiquity gene. So it inhibits the aldehyde dehydrogenase 7A1 function, as a result of which there is increased ASA level, which can secondarily, as a result of which it can lead on to the accumulation of P6C, resulting in the depletion of intracellular PLP. So there has been benefits of supplementing pyridoxine in children with molybdenum cofactor deficiency too. So what is the reason for movement disorders in children with dysfunction of PLP-dependent enzymes? Because PLP is a cofactor for aromatic amino acid decarboxylase enzyme. So the deficiency of which leads to the dopamine depletion and serotonin depletion, which can lead on to the movement disorder manifestations, tone abnormalities, behavioral symptoms, and autonomic dysfunction. So this is the enzyme aromatic amino acid decarboxylase, which is essential for the conversion of DOPA to dopamine and 5-hydroxytryptophan to serotonin. So what is the mechanism by which PLP-dependent enzyme dysfunction can result in neuronal migration defects? So this is the astrocyte, and you can find this L-serine. L-serine is converted to D-serine in the presence of serine racemase. This enzyme, serine racemase, is again a pyridoxine-dependent enzyme. So when there is a defect in this serine racemase, there is an impaired neuronal migration, and also there is impaired neurotransmission through the NMDA receptors. So pyridoxal phosphate-dependent enzymes are also important in the metabolism of serine, threonine, and glycine. So as a result of which, if there is a dysfunction of these enzymes, we can find high concentration of threonine, serine, and glycine in plasma and CSF. So this is the mechanism by which you identify hypoglycemia, as I already explained. So there are few enzymes in the gluconeogenesis pathway and glycogenolysis pathway, which can lead on to hypoglycemia, metabolic acidosis, and elevated lactate. And I already mentioned that anemia can occur because PLP is a cofactor for the delta aminolevulinic acid synthase, so which is essential for the heme synthesis. And again, it's also important for the other enzyme, cysteine desulfurase. So when there is a dysfunction of this PLP-dependent enzyme, there is disordered heme and iron sulfur cluster synthesis, leading on to the lactic acidosis. So pyridoxal phosphate is also very important in the amino acid metabolism. So among the amino acid metabolism disorders, what we encounter in the office practice is one of the disorder is the classic homocystinuria due to cystathionine beta synthase deficiency. So these children often exhibit like intellectual disability, psychiatric manifestation. They can have tall stature, they can have morphinoid features. In addition, they can have refractory seizures and can exhibit arterial and venous thrombosis risk. So other important enzyme in this list is the ornithine aminotransferase, which can again cause gyrate atrophy of retina, and rarely seizures can occur in this group of children who has this deficiency. So to summarize, pyridoxal 5-phosphate is essential for the functioning of several enzymes. Pyridoxine-dependent epilepsies are important treatable causes of developmental delay and epileptic encephalopathy. Consider vitamin B6-related disorders in any infant with unexplained refractory seizures. A therapeutic trial of pyridoxine or pyridoxal phosphate should not be delayed when the clinical suspicion is high. Pyridoxine responsiveness does not equal to a single disease. So there are a group of disorders which can exhibit pyridoxine responsiveness. So the biochemical workup in this children with vitamin B6 responsive neurological symptoms should include estimation of ASA and pipicolic acid, plasma and CSF amino acid analysis, and alkaline phosphatase level in the serum. So the molecular genetics testing help to confirm the diagnosis and also help in the prenatal diagnosis and prognostication. I would like to thank my mentors and also my colleagues, as well as trainees and fellows, who has been the constant motivation for my work in neurometabolic disorders. I'm happy to take up questions.
Thank you, Sangeeta, for a very insightful talk, as usual. Sir, Vinay sir, you want to give comments on this? Before we take the questions.
Yeah. What's the flow, Jolsna? So we will take the questions first, or we will give our comments first?
So I think if it's okay, I would want you both, sir, to share your clinical experience. You would have seen a child start off with a genetic diagnosis, and you would have followed up the child for years. And our request is if you could share your clinical experience with us about how the children do in the long term. And I also have heard you about pyridoxine-dependent encephalopathy, the concept of that. So if you could both share your clinical experience, and then we will take up the questions, sir.
See, the thing here is Sangeeta has clearly mentioned two, three things here. One is generally pyridoxine-dependent epilepsy historically is one of those disorders where very clearly without the genetics we were diagnosing these disorders. So because that is one of the oldest cofactor dependent epilepsies which has been diagnosed. And then we have the old Baxter's criteria which clearly differentiated a kind of pyridoxine responsiveness and pyridoxine dependency. And as Sangeeta has clearly told, the pyridoxine responsiveness can occur in many conditions with monogenic disorders, or even in conditions where active epilepsy with a kind of multifactorial epilepsy, you can get sometimes pyridoxine responsiveness to some extent. Even there are studies, high dose pyridoxine working in spasms without any genetic diagnosis there. So any monogenic characters. So the point is, this is a cofactor which has got a multiple level things, and it has got multiple actions. So Sangeeta has clearly told that. So one thing which I have noticed over the years, more and more, I realized that we are more stuck with epilepsy. The moment the seizures are controlled, we are happy. But most of these children, or many of these children in my follow-up, has got developmental issues, and we were attributing it into probably a late treatment, and or sometimes we are not going for a genetic diagnosis. We are actually stuck with that pyridoxine dependency only, and then we'll try to treat it like that, and then we are not categorizing it properly. And even without, see, the approach here is, I'll say that again, systemic manifestations are there, or it's a pure epilepsy syndrome. And if there is an epilepsy syndrome, we know that many of them will have a developmental consequences. Is it actually a part of the seizure, or is it part of the metabolic thing? So if you look at that, I think the antiquintin deficiency or this aldehyde adenase deficiency is definitely associated with the toxic metabolism issue. So there are a lot of questions there about that triple therapy. I think that is one thing which I think over the years I realized that we have to give more importance to that, because this is one of the commonest genes in the whole thing. Because even though she has given so many genetic diagnoses and it's a little confusing, I think the aldehyde adenase deficiency is the commonest in the whole thing. So, and then the mechanism is not in the pyridoxine pathway. It is the actually pyridoxine degradation which is happening. So there is a toxic intermediary metabolite there. And if you are clearly looking at the targeted therapy, you have to have that triple therapy, because then only the whole biochemical effects of that will be taken off. So most of my patients over the years, all of them have got learning disability, or almost all of them have got learning disability. So that means we have to have better therapeutic targets, and I feel like triple therapy may be needed, and it is much more than epilepsy. It is primarily an encephalopathy with seizures as the predominant manifestation. So Mahesh, over to you for
Yes,
your
sir.
comments.
Yeah. Sir, I'll try to share my experience. Actually, we had done a study and we published this last year in Pediatric Neurology. We had screened children between 1 month to 3 years with epilepsy, and who had a non-structural MRI. And we did a whole exome sequencing in all these 145 patients, out of which 91 patients we got positive report, yield of around 60%. And out of the 91 patients, 9 patients had virus dependency, that is ALDH7A1 mutation. This was the third most common gene in our series, following ACN1A and KCNQ2. So 6 patients had a ELDH7A1 mutation. Coming to follow-up of these 6 patients, 3 of them are doing well. So like I'd given them only pyridoxine, and 3 of them are doing well. One child is around 12-year-old now, going to school, and got average school performance. And one is a 3-year-old child who is again developmentally normal. One more 9-month-old child again developmentally normal. But 2 of them have got mild developmental delay. They're not doing that well in school. One reason what I felt was I'm from North Karnataka, and most of the times here we have people who are vegetarian, who are mainly vegetarian, and they consume less or low protein diet. And probably I think this practice of vegetarian diet has led to low protein diet, and hence probably it had acted like a lysine restricted diet also. That's what I felt. So in my practice, though I had offered them arginine supplementation, but after taking for a couple of months, parents stopped supplementing arginine, and all of them continued with pyridoxine. All of them are seizure-free with pyridoxine, and at least 3 of them are doing well. So like the remaining 2 had mild developmental delay. So I think if we can test the lysine levels, that would really help us in choosing this triple therapy. I'd like to take comments
Or
from
Sangeeta, what is your practice now? So you give the triple therapy for all the patients, or you will not do?
Yes, we start with the pyridoxine, and then I would prefer to start on triple therapy, because if we look at the consensus guidelines which was published, it states that though the level of evidence is level C evidence, because it is limited to the case reports and case series, they found that it has been found to improve the long-term neurodevelopmental outcome. So the lysine restricted diet, we don't have formulas specifically for lysine restricted, but the GA1 formula, glutaric aciduria type 1 formula, is a lysine restricted formula. But the formula which is available contains lysine as well as tryptophan. Both are restricted. But that is the one which is commercially available, which can be used. Or otherwise, what Mahesh Kamath sir was saying, like a low protein diet itself will restrict the lysine. So and like because the animal protein is rich in all amino acids, so they like, if non-vegetarians, like they might be having like high content of lysine in their diet. So the arginine supplementation, the dosage which is used is smaller when compared to the other urea cycle disorders. So here the dosage is 100 to 300 milligram per kg per day. So I would prefer to keep the child on triple reduction therapy, triple therapy, along with the lysine restricted diet.
Okay, so one question is always when we go for this restricted diet, no? So in our population, what is the chances of kind of nutritional deficiencies and other things? What is your experience in that?
Yeah, so here, like, we are not restricting the protein to the extent like what we typically do it in the other urea cycle disorders or the organic acidurias. So we can always monitor the weight gain, and also monitor the nutritional status, along with monitoring the serum albumin status in the liver function. So, and we can take a call on the diet modification based on that.
Okay, so basically I have long follow-ups of 15, 16 years of patients, and all of them have got, say, if you look at the higher level, say, one issue is if you look at very basic level of development, they are okay. But when they go into high school and all these things, they all have significant learning disabilities. And looking back, I feel like a better therapy would have been, all of them are LDH7. So I think this might be useful. That is the my experience. I feel like it is good to have that, rather than, even though we say that there are no evidence, most of the targeted therapies now in epilepsy, we don't have a real evidence. It's all case reports and consensus statements. So this is also this has got a clearly mechanistic effect and mechanistic pathway. Sorry, it's based on a mechanistic concept. So definitely it will be better. And what about this PNPO and other things? We have to have an early genetic diagnosis now, no? So Sangeeta, if we
Yes.
want to have this.
Yeah, if there is a pyridoxine responsiveness, it is better to have the genetic diagnosis, because you have a list of genes which can show, list of gene defects which can exhibit pyridoxine responsiveness. PNPO deficiency, again, like even if there's genetically proven PNPO deficiency, if the patient has like a missense variant, And if they have a good amount of residual PNPO activity, we should first start with pyridoxine trial rather than starting directly with the pyridoxal phosphate. For two reasons. One is pyridoxal phosphate is a bit expensive. Another reason is it is highly hepatotoxic. The aldehyde derivative is highly hepatotoxic, and like there is a high risk for cirrhosis and transaminitis as well as the hepatocellular carcinoma on a long-term administration. So that is like a life-threatening side effects of pyridoxal phosphate.
Okay, so you don't recommend pyridoxal phosphate in a suspected case. Even first thing is pyridoxine first, and if it is not working, only go for pyridoxal
Yes,
phosphate.
sir. Yes, sir.
Okay, and how frequently the hepatic test?
So the recommendation is to monitor the liver enzymes every 3 to 6 months or more frequently if required. And also we need to do an like if you are identifying any altered echo texture of the liver on the ultrasound, we need to do the alpha fetoprotein tumor markers also. Surveillance has to be done for the tumor markers. So if there is like the annual ultrasound has to be done in these children, but if they identify any changes on the ultrasound, then it can be done every 6 months also.
Okay, Mahesh, what is your experience? We very rarely see this pure pyridoxal phosphate dependent epilepsy.
Yes, sir. When you're we are not seeing a single case of PNPO, sir. All of them have been ELA 71.
Yeah, Sangeeta, what is your experience in this?
Similar,
Similar,
similar. In India, like I mean, I have not seen much cases in CMC, but in Sickets, like there's a cohort of children who have a PNPO, small cohort of children who have PNPO deficiency.
And any other Shafali, Mini, your experience? Because my feel like it is very, very rare in our population.
Very.
I haven't seen a case. I have seen only the pyridoxine dependent epilepsy, the classical ALDs.
Yeah,
And
that is very common. That is very common. I think
and then I
Rajesh
have
was,
found some usefulness with the KCNQ, that encephalopathy part comes once the pyridoxine is taken away. So one of my patient develops always encephalopathy. Rather than seizures, he comes back with the encephalopathy. The moment pyridoxine is put, his encephalopathy clears. Another patient actually, he had a pyridoxine, we had given ALD7 mutation was confirmed. While on pyridoxine, full dose pyridoxine, he had gone in for West syndrome, like spasms. He had a corpus callosum, like thinning of corpus callosum and all, and he did not have any other abnormality in the MRI also, no other gene abnormality also in the BS. But then the patient, in spite of putting the full dose of pyridoxine and using pyridoxine phosphate also, he did not respond. Cholic acid, triple therapy, everything was given. But later the spasms got control. Even with ACTH, it did not get control, Vegabatanol. He had to give topiramate and then it got control. Now he is off those anti-seizure medications, but again, he has autistic features. This is my experience.
So
and
it's
we have
an
some PIGA mutations.
It's an anti-kidney deficiency, which
we have some cases with PIGA. We have some PIGA mutations. Patients with PIGA mutations who have partial response to this pyridoxine, not very fully controlled, but partial response. Not that all of them are seizure free, but majority of the seizures are now reduced with this.
Okay, so I think the feeling is we have cohorts here in Kerala, especially certain parts of Kerala when they are coming with this kind of. We know that this can be a pyridoxine dependency, and then there are biotin deficiency, biotinase deficiency groups also in certain populations. So the overall feeling ALDH17, I still feel like the outcome, the developmental outcome compared to an early, even if we start pyridoxine early, the developmental outcome is not that great compared to biotinase deficiency. Biotinase deficiency, they are completely normal kids in every sense. But here we are not getting that even with the kind of even early treatment. That is so that's why the role of triple therapy over the years. I feel like there is a role with this. I think Mahesh, we can hand over it to the moderators for the taking questions from this.
Yeah.
Yes, I think some questions were repeated, but there are some very practical and pertinent questions. I'll start with Dr. Sridhar's question. When we switch from pyridoxine to PLP, do we stop pyridoxine altogether?
Yes.
That is his question.
Yeah. So when you're switching from one like pyridoxine to pyridoxal phosphate, you have to discontinue pyridoxine and then start with the pyridoxal phosphate.
Yes, ma'am. So is triple therapy optional to improve the outcome, or is it? I think we have discussed this. Ma'am, one quick answer for this.
Yeah, so as per the level of evidence, though it is a level of evidence is C, so it would be recommended to give triple therapy because it might improve the long-term neurodevelopmental outcome.
Right, ma'am. The next question is on pyridoxine-induced neuropathy that pediatric neurologists should actively screen for. So do we
Yeah.
screen?
Yeah. So if you look at the Pyridoxine Dependent Epilepsy Consortium, the guidelines, so the peripheral neuropathy risk is high if the daily dose of pyridoxine is more than 500 milligram. But we also saw that the ceiling dose even in the adults, we tend to keep it below 500 milligram. But there is again a large data or systematic review which identified like individuals who are on more than 50 milligram per day for more than 6 months, some of them developed peripheral neuropathy. So the current recommendation, if the child is on high dose of pyridoxine, it is essential to monitor clinically to look for any evidence of any dropped reflexes, deep down reflexes, or any wasting or weakness, and also to plan an electrodiagnostic procedures annually if the child is on high dose of pyridoxine.
Yeah,
Okay.
Sangeeta, one question here. So is it really related to any specific genes or anything? Any data on that?
No,
The
sir.
toxicity is across board for every child with high dose pyridoxine, or is it specific?
No, sir. It is just related to the high dose of pyridoxine. It's not related to the underlying mutation.
Just one question, Sangeeta. Is it a sensory neuropathy which is common, or a motor weakness also comes with this?
So you can have both motor as well as sensory.
Right, ma'am. So I think there is another question on lysine restricted diet only in ALDH7A1 or other mutations.
Yeah,
I think
so,
this was there in the talk. Yes, ma'am.
Yeah. So this is only for aldehyde dehydrogenase 7A1 or antiquintin gene defect, because you know that lysine degradation through saccharoperin pathway, the defect here is in the saccharoperin pathway. So it won't help aldehyde dehydrogenase 4 or A1 or the other genetic mutations which show vitamin B6 responsiveness.
Yes, ma'am. How crucial are lysine restriction arginine supplementation for ALDH7A1? Is it a must in all cases?
That's the same question. No, same question. Don't repeat.
Same. Yes. So, adult neurologist here, there is a theoretical consideration that levodopa can lead to excess consumption of pyridoxine through activation of dopa decarboxylase, leading to seizures. And any comment on this?
Yeah, high dose of levodopa can lead on to the depletion of cerebral folate. I'm not sure of consumption of pyridoxine, but cerebral folate deficiency can occur. So because it will be converted to 3-O-methyl dopa, and for this reaction they will consume the methyl group. This can result in the cerebral folate deficiency. So they can be supplemented with folinic acid, but I'm not sure if it causes a consumption of pyridoxine.
Okay. Then do we wait for, Sridhar is asking, do we wait for 1 to 3 days for adding vitamin trials for unexplained infantile refractory seizures, or together? Is it a sequential vitamin trial versus a together trial?
It's a sequential trial, because if you add up all of them together, you will not know which has caused responsiveness. So you will not be able to withdraw the other medications. So it's a sequential trial over 1 to 3 days rather than a simultaneous adding of all.
Okay, ma'am. So I think this is also a repetitive. What is the cause for developmental delay due to seizures or metabolic causes with pyridoxine? Lysine restricted diet can prevent encephalopathy or improve neurodevelopmental outcome. I think that is the meaning of that question. So we have answered it. And is Syndopa helpful in movement disorder spectrum of this?
Oh, it won't be helpful, because I said like the PLP dependent enzyme is aromatic amino acid decarboxylase. So aromatic amino acid decarboxylase is essential for the conversion of dopa to dopamine. So if you give an L-dopa, it won't be converted to dopamine. So only the L-dopa level will be high, but that dopamine synthesis doesn't occur. So you can try dopa agonist, not a syndopa.
Right, ma'am. So I think the next two questions are answered in terms of screening when a child is on long-term pyridoxine. What determines the difference in response to B6 therapy? Some need low B6, other need higher doses, some triple therapy. I think, ma'am, the dose of B6.
Yeah, so the difference in the dosage of B6 may be determined by influenced by the underlying mutation, because if you have like nonsense or a stop codon mutation, then the amount of functional protein or the enzyme would be very minimal. So those children might require a higher doses.
Is there a possibility of an enzyme dependent analysis based, like we have a mutation, and then can we do an enzyme analysis and decide that what is the extent of the what is the burden of the disease?
We don't even have biochemical markers, but
Yes,
if you have like a fantastic setup, wonderful setup, of course you should do it.
Yes, ma'am. And Dr. Vaishak asks a very practical question. Should we avoid dissolving pyridoxal phosphate tablets in water, since some say it leads to oxidation?
Yeah, pyridoxal phosphate, there is no contraindication for dissolving in water because it's a water soluble vitamin, but like it gets degraded faster, so it becomes unstable in liquid form. So only the tablet forms are available, no liquid forms are available, and it oxidizes rapidly when it is exposed to the light and air. So if the child cannot consume the tablet, it can be dissolved in water, but has to be administered as early as possible.
Got it, ma'am. So measurement of pipiculic acid and the usefulness as a biomarker.
Yeah, it is definitely useful if you have a facility to estimate it, because the problem with this neurotransmitters, pipiculic acid and ASA, is they are all thermolabile. So you need to have a very stringent precautions for collecting the samples and maintaining the cold chain temperature. So if you have the facility, of course, it is definitely a good biochemical marker.
Yes, ma'am. So Dr. Mini ma'am has asked, you had mentioned that some anti-seizure medication should not be used. Then in some cases, pyridoxine-dependent response and responsive epilepsy first responds to phenobarbital, ma'am. How is it acting then? I didn't get PB.
Yeah. So it is. Yeah.
Yes.
So certain anti-seizure medication like phenobarbital, phenytoin, carbamazepine, and valproic acid can cause intracellular depletion of pyridoxal phosphate level. So in case if the seizures are not settling down despite the pyridoxal phosphate supplementation, maybe you should consider changing your anti-seizure medications.
No, the question here is the pyridoxine ALDH 17, the antikythine. So whether it will respond to phenobarbital first.
Oh, yes. So the classic one does not respond to the first line anti-seizure medications, but the atypical forms initially may show some response to anti-seizure medication, but again later they will have refractory seizures.
Okay. But for that, we don't have a population study in Sangeeta. Because how can we be sure? Because we usually do it, we are not giving pyridoxine to all neonatal seizures first to be sure that they are not pyridoxine-dependent epilepsies. We are giving phenobarbital or some other drugs first. And if some of them respond, we are not doing the genetic study. No?
Yes, sir.
So there is a selection bias here. So there is a question, there is an availability of a syrup form, no? So that is an important question, I think. There is a syrup form of P5P here. So will we use that, or is there a problem?
So liquid form is highly unstable. So it is not preferred.
Okay. So any other thing?
I think that answers it. The pipiculic acid part, madam has already answered as a biomarker.
So in general, I have asked one more question, like vitamin responsive epilepsies. When you are choosing, if you are forced to choose anti-seizure medications, what precaution should you take? Like maybe patients are on anti-seizure medications already before they are diagnosed. So how fast should we take out the other anti-seizure medications like biotin responsive epilepsy and all? And also pyridoxine. You have already told regarding pyridoxine. So in general, what should be the?
Yeah, if for biotin deficiency, usually they have dramatic response to a very low dose of biotin, ma'am. So 5 to 10 milligram, if you give, they usually respond within a week. So if they have a good seizure control for 3 months, I think there are no definite guidelines to determine at what point of time the anti-seizure medications can be tapered. But if the child has a good seizure control, and I think we can always give a trial of withdrawal of anti-seizure medications.
But Sangeeta, the question is pyridoxine-dependent epilepsy.
For the
Usually
paradox,
many times we feel like it is not that easy to come out of
yeah,
the anti-epileptic drugs.
yeah, because if they have like a refractory seizures, if the child is already on multiple drugs like 2 or 3 anti-seizure medications, and the child has attained a good control after adding a pyridoxine, till the time we get the genetic testing report, at least we have to maintain on all this. But once we have the genetic testing report, if the child has a good seizure control, maybe we can try attempt tapering 1 or 2 medications gradually. So again, there is no clear guidelines at which point of time it should be tried, whether after 3 months or 6 months of seizure control. There is no clear guidelines on that.
Does interictal EEG help, ma'am?
Although interictal EEG may be normal in these children.
See, most of the pyridoxine-dependent epilepsies we will get only during the ictal phase. So unless they have got a kind of encephalopathy or some other rare, the other genetic disorders which Sangeeta has told. So in the classical pyridoxine-dependent epilepsy, usually interictal EEG will be normal. Or you can get the syndrome. It depends on the syndrome. Sometimes, very rarely, you get this early infantile epileptic encephalopathy syndrome. If you get that kind of a syndrome, it is sometimes you may get, but otherwise the EEG may be normal many times. Interictal EEG, what I'm telling.
Yes, sir. I think that finishes the questions. I hand it over back to Dr. Mini ma'am and Dr. Shefali ma'am.
No, Dr.
Thank you,
Shefali, you can conclude.
Okay, thanks. Yeah, I think it was a wonderful session and wonderful discussions. And thank you, Sangeeta, Dr. Vinay, and Mahesh, and Lokesh and Jyotsna. And we come back next month again with another, very interesting session. So see you next month. Thank you.
Thank you all for calling us. Yeah.
Thank you.
Thanks for the invitation. Good night.
Bye. Good night.
Thank you, everyone. Good night.
Thank you.
Thank you. Thank you.